Testing, testing. Morning, Debbie.
Good morning. How are you?
Good. Waking up here.
Yeah, it's early.
Yeah.
Gosh, it's gonna be another hot day too.
Yeah, I think I heard 88 today. Is that right?
Yeah, something like that. My husband was kind of grumbling about it when he left
Yeah.
home this morning. I'm kind of I like the warm weather, but I kind of like a little bit less, maybe like
Yeah.
kind of high 70s, low 80s. I'm perfect with.
Right there with you. It sounds like
Yeah,
Hawaii weather.
yeah, yeah, exactly. Do you want me to try to share my screen really quick to go through that?
Yeah, sure. We can test it
Okay.
out.
Um, Did that, oops,
Yeah. Yeah. Looks
can
good
you
to me.
see, can you still see it?
It's a little bit small, but if you want to zoom in a little bit, but otherwise looks pretty
Yeah,
good.
okay. Okay, perfect.
Awesome.
Stop share. Okay, well, we got that hurdle, so that's good.
Yeah.
That is working.
So far today.
It's for some, I like to square up, like.
Yeah. Morning, folks. Just waiting for more of our panel to join and we'll get started in a moment. Good morning, everybody. Waiting on our co-chair to arrive and we'll get started in just a moment. Good morning, folks. Good morning, Bruce.
Good morning, Jamal.
Looks like we've got a good group here today. Do we want to give it another moment, Bruce, before we get started, or did you want to get going?
Well, I'm double checking to see if I think we're still waiting on one person who you suspected had a member announcement. Give it
Yes.
just another 30 seconds.
Yeah, that's right. Bhavesh, I believe, has an announcement from Pacific Source. So we'll give it another moment here.
Jamal, can you tell me if my background looks like NWSCS is backwards?
No, it looks great.
Oh, it
the
does?
your
The image
function
I
down.
see, it
Alright.
shows it backwards.
Yeah, no, it looks perfect to us.
Okay.
You'll have to teach me how to do that at some point. The other thing, Bruce, is we'll need to give it a moment to ensure we've got a voting quorum as well as we've got a few things that we're looking to approve today.
That's correct. I do have a motion and early on here in the member announcements even, so.
That's right. Okay, so we'll give it just another moment here. I'll check in with Bhavesh.
Good morning, all. Sorry I'm late. Just letting you know that I joined twice by phone and by camera.
Got it. Thanks, Dr. C.
Well, Jamal, do you think we can kind of reverse it real quick? Can we maybe start off with attendance and hopefully by then he's joined so that way we can keep
Yeah,
things moving.
I think that's a good idea. So I can kind of go down our attendance list here if folks just want to call out that they're here. Okay, let's start with Dr. Sellers, gotcha.
Here.
Naomi is out on vacation today. Bhavesh, is he here? Okay, we'll circle back with Bhavesh. Dr. Carroll,
Morning here.
morning. Dr. Teshador? Is Carlos here? Okay. Dr. Chaudhry,
Present.
Dr. Carolyn King-Woodall,
Yeah, I'm here.
morning. Annie Willems. I see Annie on mute. Okay, Dr. Kalik Williams. Dr. Castillo. Is Carolyn Castillo here? Phil Blair. I see Phil on mute.
I'm here.
Hey, Phil.
Good morning.
Lavinia.
I'm here.
And Alicia Calthrop. And Dr. Haller.
I'm here. Morning.
Morning. Russ Huffman. Jody Peterson.
Here.
Prashanti.
Here.
Dr. Tony German.
Present by phone.
Hey, Tony. Dr. Rasmussen.
Good morning, I'm here.
Morning. Dr. Fraser. And Krista.
I'm here.
Okay, Dr. Sellers, we have a voting quorum.
All right, and I see that it looked like Bhavesh had joined us as well. Bhavesh, did you want to make your member announcement that you had planned for today?
Sorry, trying to get myself back off mute as well. Yes, the announcement is simply that the clock in the past had off. And so
We're having a hard time
Bhavesh,
hearing
it's
you.
it's a little bit hard to hear you.
Sorry to interrupt.
hold on.
Bhavesh, are you there?
Can you hear me now?
Yes,
Yeah.
much better. Hello, Bhavesh, are you there?
Sorry, can you hear me now?
Yeah, loud and clear.
Yes, sorry about that. So the announcement is simply that we at Pacific Source had been requested if medications could be given for a 90-day period at a local pharmacy. And up till now, you could only get a 90-day supply when requested through the mail order. So it took a moment to readjust the way our system worked, but it has been approved and it is now active. So when a member's on chronic medications and a provider wishes to write a 90-day supply, it can be written from a local pharmacy. That's all. Thank you.
Thank you. Thank you.
Thank you, Bhavesh. That is remarkable work. Really appreciate it. That's a big deal.
Thank you.
If there's no other member announcements, I'd like to put it right off the bat. We do have some member prospects. First of all, we've got Ryan Davin. I hope I pronounce everybody's name correctly. I do my very best. Who's executive director with New Perspective Center. Ryan's a licensed clinical social worker and certified alcohol and drug counselor who has worked in the field of behavioral health for 14 years. We've also got Dr. Danielle Shannon, pharmacist with over 16 years of extensive full-time experience, ranging from community pharmacy to primary care to managed care. And then we've also got Lisa Ladd, who's the senior director of contracting and network management with Willamette Valley Physicians Health Partners. And Lisa's she's been in the profession for over 30 years with health plan contracting and network management. I would like to go ahead and put it before the CAP membership as a vote to vote them in as new members. Jamal, do we have a voting quorum so we can go ahead and proceed with that?
Yeah, we do have a voting quorum.
All those in favor say aye.
Just a quick note, Dr. Sellers. So really excited about the folks who are interested in joining the panel. These are our leaders in our community, doing great work as regional partners to so many of our healthcare providers and in direct service to our members. So one quick note is Krista Lavas with WVP has requested to step down from the panel to allow for Lisa to take her place, as Krista has requested that Lisa join the panel as she's got extensive experience in primary care transformation and value-based reimbursements that they believe will be beneficial to our panel, especially as we engage in more investment decisions and quality improvement initiatives across the community. So in the interest of keeping balance in the panel, Krista has requested to step down so that Lisa could join, as well as Dr. Shannon, who brings clinical pharmacist experience, which is somewhat of a gap for our panel at this time. So I just wanted to provide a little bit more context there for folks in terms of the two WVP folks joining the panel.
Jamal, would it be possible to say a little bit more about how the CAP is comprised, how the membership is comprised, if there are seats that are required, or how we put out a request to have new members apply?
Yeah, certainly. So at this time, according to our bylaws, there's not a limitation on the number of members that could join the CAP. We do have specifications within our charter that indicate that folks joining the CAP should be direct service providers or involved with sort of the quality aspects of their organization, which all of these folks are. We really work with our co-chairs to identify where there are gaps in representation, whether that's behavioral health or from our regional tribal governments and tribal health services, and start sort of that organic process to understand in the community who's interested, who's available, and have those conversations to where we can bring a listing of folks to our co-chairs to determine if we want to bring that before the CAP for a vote.
So I'd like to motion to approve these three new members into our CAP. Is Jamal, do we want to go with ayes and nays, or how do we want to proceed with this today?
Yeah, I think just a verbal, we'll give folks a chance to say aye or yes.
And Bruce, I think you need a second and then you can go to the votes.
Okay.
Yeah, I'll second it. It's Matthew Hatler.
With the second, we can kick off the vote, Bruce.
Okay, well then, let's go ahead and let's vote, please.
Aye.
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 And Bruce will ask if there's any opposed.
Is there any opposed? Looks like there's no opposed, so we're gonna go ahead and move forward with adding these 3 new members to our CAP, and we look forward to their expertise in our panel. Jamal, I know we're running a little behind, so I'm just gonna kind of go through the quick overview so we can take over. Or more so you can take over. Let's see here. So we're gonna go through the CAP shared savings initiatives. Jamal's gonna kind of go through these. I know that people have already had the options to weigh in.
Bruce, really quick, do we want to just give a moment to see if there's any public comment?
Oh, I apologize. This is a public.
No worries.
This is a public meeting. We do have a very limited time for comment as we are very much behind right now. So is there any public comment? All right. With no public comment, we've got 2 items ahead of us. And then after that, Jamal will be taking completely over. We've got our CAP shared savings initiatives with our progress from last month. We have already seen progression to the point with initiatives. And so Jamal will review those, after which we will have a discussion on the Salem area gun violence prevention discussion, led by Debbie Aguilar from Salem PD and Ben McBride from Empower Initiative. And Jamal will kind of keep us on track from here on out. So Jamal, you're up.
Thanks, Bruce. So as most of you have seen in the CAP shared savings requests that have come through our online voting form through JotForm, we've got 2 initiatives that have been recommended by our shared savings work group. So the first of which is our Connecting Perinatal Care and Support Providers initiative. So this really stems around hosting a 2-part networking event, beginning with a webinar in the fall that would be geared towards gathering input from the community of stakeholders on perinatal care throughout the region, gaps that folks are experiencing, models of care and ideal referral pathways. And when we use the term perinatal care, we're really talking about from the start of pregnancy to 1 year for the child. So that 90-minute webinar would lead to an in-person networking event in October, where those regional partners and leaders would come together to share best practices and ultimately network to ensure that there are optimal referral pathways and as seamless an experience of care as possible for families and babies. Lastly, this would culminate in an ongoing digital resource library that those regional partners would be able to see what resources are available, not just in provider services, but also those community-based organizations and support services, such as birth doulas and programs through DHS. So this has a $75,000 budget for the event, as well as the ongoing digital resource library. The beneficiary organizations are to be determined as the Childhood Healthcare Access Work Group and the council would be working to identify the digital resource compendium. We've been in talks with Connect Oregon and Pacific Source about the powering of what's called Polywog in the Lynn Benton region, which has worked very well for that region to ensure better coordination in this space. And so that's one of the areas that we're looking at utilizing for that digital resource library. So I want to pause here and just open it up for discussion from the CAP membership, and Bruce, if we want to, if folks are on board, we'd be happy to move this one forward for approval and get this initiative going. But before we do that, why don't we open it up for any questions or discussion?
This is Manu. While I am in support of anything that could advance what this is promoting, I'm a little bit confused a bit on, or seeking clarification on what the $75,000 are going to be used for. What I read here is a two-part networking event. So it's 2 networking events and then an interactive webinar. And it is, yeah. Can someone help dissect that a little bit?
Yeah. So it's a 2-part networking event and then an ongoing digital resource library. So basically an online web page that will collect all of the information from regional partners. So the biggest majority of this budget is for that online website to effectively host and continually update the resource library. There's an additional 10,000, I believe, that's reserved for speaking fees, and then 15,000 for sort of the venue space and catering.
Hey,
This is
this is Russ
Caroline.
Huffman.
Sorry.
Go ahead. No, go ahead.
So the digital web page is connecting community resources such as doulas, and I'm not sure what else. And it's patient facing, is that correct?
Yeah, it is intended to be available to the public.
Mm-hmm. So the public can find doulas basically, or are there other things that they would find on this web page?
Yeah, that's a great question. So it would be intended to host really the entirety of care and supports around that perinatal period. So and not just sort of a basic listing of folks, but sort of ideal referral pathways and connections. So we'd be talking about pre and postnatal providers, OB labor and delivery providers, DHS programs such as the Safe Infant Sleep program that Cindy Nestor has a lot of great information on, and many of our community-based organizations that can address social needs as well as behavioral health providers. So really intended to be a centralized space that when folks are pregnant or we've got newborns in our community, there's that more seamless understanding of how to create a better experience of care and a more coordinated experience of care.
Another follow-up question. Who's the owner of this? Is it WIC? And I think Caroline also addressed another follow-up question that I had in my mind as well.
Yeah.
Via chat.
So the owner of this is effectively our Childhood Healthcare Access Work Group. So the council will be taking lead, at least in the short term. Through Pacific Source, we do have our social emotional health aspects, health
Aspects of kindergarten.
Health aspects of kindergarten readiness. That is a mouthful of a QUIM. So we have a work group that receives funding to ensure that we've got a robust infrastructure and community capacity for these types of services and supports as really for that 0 to 5 age range. So I think we will be looking to have those discussions around sustainability through utilization of that work group and that area of Pacific Source that is driving that forward.
This is Josie. I would just add the Marion and Polk Early Learning Hub, which is a key partner in that work group. Has expressed interest in taking this over from a sustainability perspective and maintaining the information. So our work group would come together to help get it started, make sure we have, all available resources in the region represented, and then hopefully the hub could take over maintenance and keeping the database up to date ongoing. And this also connects really nicely to some of the upstream initiative work that the hub is also leading in the region. So hoping to connect some of those dots to keep this going in the future.
Thank you. That's very helpful information, Josie.
You bet.
Great questions. I'm just checking the chat. I see from Carolyn, she stated, when they say ongoing, how long will this budget cover the ongoing maintenance of the webpage? That's a great question, Carolyn. So the 50,000 that's carved out for the webpage is really around implementation and establishment for that first year. Ongoing as Josie had laid out through the work that's happening with the Marion Polk Early Learning Hub and Pacific Source. We'll be looking to fund on an ongoing basis through that work that they're already doing. And I see that Annie said, while people can currently go online to find doulas and other providers, the way they are listed by county, and it's not at all user-friendly to the public. And that's exactly what our childhood healthcare access work group has been expressing in terms of a need for this sort of centralized, more user-friendly platform. So, okay. Heather, I see that you've got a statement in there. We're going to come back to that, I think, offline in the interest of time. Dr. Sellers, I'll send it back to you. If we want to, if we feel like we want to put this one to a vote to move forward, or if we want to take it offline and take any more questions.
No, I feel like everyone's questions were regarding details, which I believe you answered. And I feel as long as you've answered it to the satisfaction of the committee here, I think I want a motion to put this to approve it. So I would like to motion to approve.
Actually, can I just make one other comment before we move forward? I think, sorry, Dr. Sellers and Jamal, while it states the QUIM impact is there on the upper right, I just want everyone to know that that's not a direct QUIM impact. It's something that's gonna, we're adding information, we're connecting people, and eventually the QUIM impact could maybe affect us in 25 or 26. Just wanted to note that for everyone for the sake of the thought of it. Thank you.
That's a great point. Okay, Dr. C, did you say that you second?
Yeah, I'll second.
Okay. And I think Dr. Sellers may have needed to step away for some clinic care. And so I suppose we can put it to a vote here if so. All in favor?
Aye.
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 Okay, and any opposed? And any abstentions? Okay, motion carries. So, moving forward here, we've got one more. So this is really a continuation of the work that the council has been doing in partnership with so many in the community to prevent kiddos from being excluded from school due to not having all of their vaccinations current. So this is really an expanded school exclusion day outreach campaign that would take a lot of what has been done and make it more consistent throughout the school year. This would also involve additional incentives that would be targeted to different historically underserved communities within our areas, such as gift cards and other sorts of gifts that would be culturally appropriate for folks. So instead of really a limited outreach campaign that centers around school exclusion day in the January to February timeframe, this would really be picking up in August 2024, so leading into the back to school time period and continuing on throughout the school year. This would 15,000 would go to the existing contractor that's used for outreach, which is Vive Northwest. And then an additional 30,000 would be set aside for incentives to community members to assist with vaccination. So we are looking at WVP as a partner in disseminating those incentives out to the right communities at the right time. So let me open it up for questions, thoughts on the expanded school exclusion outreach day, school exclusion day outreach campaign.
This is Dr. Hattler. I like this, and I like that it is promoting more of a year-round approach to attacking this difficulty. I do get a little concerned about, offering gift cards for people to get vaccines. I don't know if that opens us up to any liability, like if it's seen as we're, essentially kind of paying someone to get a vaccine, like is that ethically a problem? That's my only concern about this one.
Certainly. And Josie, did you want to talk a little bit about some of the conversations that the work group had around gifts?
Yeah, and I think Dr. Hatley, you raise a really valid concern. The work group has learned from the experience of WVP. So over the last few years, WVP has had a pot of money available and has made those funds available to clinics within their network to provide incentives for folks to come in for well child checks, things of that nature. So we'd really look to partner closely with WVP in that space to help advise how best to get incentives out to clinics and then directly to patients. We have a member of the Russian Old Believer community on our work group, and she expressed concern around gift cards in particular and how that might be perceived within her community. So the work group had some good conversation around, could we purchase with those funds puzzles and coloring books and age appropriate books for kids and use those incentives for parents to bring their kids in. There's going to be a lot around just educating about vaccines and what school exclusion day is, but a prime focus on really connecting kids back to primary care for a well child check. That's going to be a big goal. So again, working with WVP, learning from that history and our trusted advisors on the work group to get those dollars out into the community in an appropriate way.
Great, thank you.
Yeah.
Yes, hi. At that, we serve.
So Bhavesh, it sounds like you're cutting off. We can't hear you very well.
Yeah, you're breaking up.
It's very like staticky.
Bhavesh, why don't we come back to you? I see that Dr. German.
Apologize.
No worries. We'll come back to you, Dr. German. I see you've got your hand up.
Yeah, thank you. Really excited about these two initiatives. My questions around just kind of process to, I'm curious, as we're proceeding with this idea of the shared savings, of evaluation of the, our interventions, and are they effective strategies, and also just kind of learning for our next steps. So I was just kind of curious about if there are tools that we're looking at or reflecting upon doing is how we're measuring what we're putting forward in these projects. Are we, and not to be too cumbersome, because as far as too much study into it, as far as those dollars go, but I'd just be curious, are we getting return on what we expect to happen?
Yeah, that's a great question, Tony. And it's part of the process of the shared savings work group to determine just that, right? As initiatives come from far and wide from our community, we're looking at the what exactly is that return on investment? We've only got a limited amount here for a limited time, and so we need to ensure that it's not first come, first serve, but it's really those that are impactful for the broadest array of folks in our communities. And so through the application form that requesters fill out, they're required to lay out the outcomes that they seek to drive over the next 12 months and 24 months, as well as who is the focus population that they're focusing on, and then health equity considerations as well, right? So there's a specific question around how will the initiative reduce health disparities, and for what specific populations will the initiative reduce disparities? And then from there, we're asking them to really lay out how performance will be measured. So after any initiative is approved by CAP, the council itself will connect with those individuals to initiate sort of the grant tracking process and ensure that the mechanisms for measuring performance over time, which we've agreed to bring back updates to the CAP at least every 6 months for every initiative that's approved. But during that grant tracking process, myself at the council will be ensuring that before we actually disperse funds, there's concrete means for requesters or approved requests to track performance.
That's great, Jamal. Thank you. Yeah, I just think, learning, we've done this a couple times, and just thinking what robust outreach strategy means. I know we're continuing to refine that and learn from that, but I think just an assessment and holding these initiatives accountable is part of my question. So I appreciate those efforts, and thank you for that reflection.
Certainly. And Jody, I see you've got your hand up.
Yeah, I was just curious how we would partner with outside entities. I know I was on part of this, but I don't see it in here, how we'd partner with schools and such to get more students headed that way. We usually have that data in the county. And so is there other outreach than just clinic level?
Yeah.
Yes.
Yes,
So
it
the
is.
incentives will be managed through WBP and distributed to clinics, but in terms of the outreach campaign, Jody, we're going to take a very broad approach. So lots of partnership with schools. We're trying, Jamal's been leading this effort. We're trying to get a representative from Willamette ESD on our work group so we can really reach a broader swath of school districts within the region. County public health departments will continue to be engaged. We have culturally specific community-based organizations that are engaged. So it's going to be a broad community effort in terms of outreach. And again, the goal is to connect students back to their primary care provider if they have one.
Thank you.
Okay. Do we have a motion to fund the expanded school exclusion day outreach campaign?
Motion to approve.
Second. Alrighty, all in favor?
Aye.
Aye.
Aye. Aye.
Aye.
Aye.
Aye.
And any opposed? And any abstentions? Okay, motion carries. Thanks all. This is a new process for us, as we all know, and I think we're seeing that it certainly takes more time and deliberation. So we'll be sure to kind of carve that in as we lay out our future CAP meetings, as we know the community has a lot of great ideas for improving quality, and our goal is to bring that forward to all of you in a transparent and accountable fashion for us to drive those outcomes. So we look forward to going over these initiatives at additional CAP meetings as well, and in between our CAP meetings. So I'm gonna keep us moving forward here. We are a little bit behind, so we might move a few items around in our agenda and postpone a few items, but I want to turn it over to Debbie Aguilar with the Salem Police Department, as well as Ben McBride with the Empower Initiative to discuss an important initiative that has been requested from this group of great interest, given some of the recent gun violence and trends in gun violence in the Salem area. So Debbie and Ben, I will turn it over to you.
Thank you. Ben, I don't know if you're good with this. I have a document to share with everyone and kind of talk about where we are or where we were and kind of how we got here, and then turn it over to you to talk about some of the community-based intervention and prevention strategies, if you're good with that. I'm gonna
Sounds great.
Okay, I'm gonna share my screen. Okay. Just want to confirm, Jamal, you can see that, right? I know we checked earlier.
Yeah, everything looks good.
Okay, perfect. Okay, so like Jamal said, my name is Debbie Aguilar. I'm a deputy chief with the Salem Police Department. I oversee our investigations division. And so that is basically all the detectives. So the detectives that are out there both responding to and investigating these shootings, as well as trying to prevent. So Chief Womack wanted to be here. He's out of the office today, so he asked me to cover. And then, of course, Ben is here because he is the expert in this topic and has a wealth of knowledge to help move us through this process. So I wanted to just share with you this document. This document is available on the police department website. So if you want to take a look at it, if you want to copy it and share it, you're welcome to. And then I'm going to talk about two different studies that we did just really briefly. Those are also available on our police department website that you can download. If you're a data geek and like to read in depth about that, you're more than welcome to. I think it's really ironic that, or timely, I suppose, that we're talking about this topic, given that we just had 3 recent shootings over the weekend. We had one that was, it was a non-injury. However, there were about 40 shots that were fired. So ironically enough, nobody was injured in that one. We had also an injury shooting with an individual who was not interested in participating in a criminal investigation. So he was injured, but he'll survive. And then we also had a homicide. It occurred just slightly outside of the city of Salem jurisdiction, so it's technically a Marion County case. However, we know that these individuals don't abide by jurisdictions. They come in and out of the city, and so what happens in the county obviously affects us and vice versa. So this document really gives you an outline, a good outline of what our community violence reduction initiative is. It first kind of defines what community violence is. I think it's important that we're all on the same page and that we're speaking the same language, that we're not really talking about violence that happens within the home, so domestic violence, but we're talking about violence that generally happens outside in the community, with individuals who are generally unrelated. Sometimes they may or may not know each other. And so we see this in Tillamook, in Salem a lot with shootings in public places. I don't know if everyone remembers the shooting downtown at Salem Center Mall, and especially out on the streets as well. So anecdotally, officers have noticed that there has been an increase in violent crime. The Chief Womack came from California and has been involved in this work. And so he really took an interest in what officers were seeing out on the streets. They were seeing individuals who were armed with guns. They were seeing individuals who were willing to use those guns. So he asked that internally we conduct a 15-year crime trend study. And that study looked at both property crimes as well as violent crime. And it looked at it from a lens of 15 years. So we do have ebbs and flows when it comes to crime, but when you look at a trend over 15 years, you really get a sense of, is it an upward trend or is it a downward trend? And ironically enough, property crime was slightly trending downwards, but violent crime really was trending upwards. And you can see in here in the facts and figures that the data really did show that about 42% increase in violent crime within that years, and that fatal and non-fatal shootings. So when we look at violent crimes, we're looking at robberies and rapes and all these type of personal person on person crimes. But we also saw that fatal and non-fatal shootings, which is really what we're concerned about, doubled in the last 5 years. So because of that 15-year crime trend study, we reached out to researchers to really take a deep dive into that data and give us an idea of what is happening within our community related to community violence so that we can use that to help develop an effective response to this violence. So that data, those researchers came, they took a look at the data and they gave us some high points. And I've got them here on this document that you can read. But what it showed us was that the violence was occurring within a fairly small area within our city, about 5 square miles in the northeast Salem. And that generally was driven by personal disputes, whether that was over money, relationships, drugs. Really, that was driving a lot of these shootings. And it also told us who was committing these shootings. So primarily, both the victims and the suspects were kind of that young adult to kind of mid-adult range, so the 18 to 34. And really, the male gender was primarily who was either being victimized or engaging in the shootings. And then the researchers also looked at race and saw that about half, a little over half of the victims and suspects were Hispanic. Juveniles, definitely, anecdotally, we have seen an increase in juveniles both being victimized and perpetrating the violence. And the data did show that about 18% of the suspects and 10% of the victims were juveniles. We have seen an increase in juvenile gun violence. This recent homicide, the victim was a 16-year-old male and the perpetrator was an 18-year-old male. So it did fit in line with what we are seeing. We did see that there were some homeless individuals who were involved in the community violence, both as a perpetrator as well as being victimized. And then when we looked at, were there any gang or group affiliations, we did see that in almost half of those shootings that there were some kind of gang or group involvement by either one or both individuals. And then we also looked at what was their prior criminal history. Were they involved in the criminal justice system? And really saw that about 70% were involved, have been involved in the criminal justice system in the past. And in fact, there was a portion of those individuals who were on either active supervision, probation, or post-prison supervision when they were either victimized or engaging in that violence. So all of this data, we took all of this data and then decided we really needed to do something about this, but we needed some help. We needed someone who had the expertise to help us take what we know now. Now we have a good idea of what are we looking at? And we needed an individual to help us develop a strategy. So what we decided to do was develop this CVRI, or Community Violence Reduction Initiative, that really has two concurrent efforts underway. So we have a criminal justice system effort. So law enforcement partners within the area are working together on a task force. We also have some new technology that we're using to help identify individuals who are engaging in this violence and hold them accountable. But then we also have a community-driven or a community engagement strategy or effort that is really focused on community-based prevention and intervention strategies. And that was where we consulted and hired Ben McBride, who again has an expertise in this area, and he's helping drive that effort. I don't know, Ben, would that be a good dropping off point to throw it over to you?
Sure, and I'll be brief. You did a fantastic job in laying all of that out. So I will just come in to underscore some things that you shared. I just dropped a link in the chat to a white paper report, case study and hope that the Gifford Center did. Also has now been kind of held at the Center for Policing Equity, coming out of Washington, D.C., as well as serving as the evaluation report to help guide a lot of community violence reduction initiative strategies that are happening around the country based on the work that we did in Oakland. And in essence, everything that the deputy chief just shared are the normal trends of what we learned and understand about the data in relationship to community violence. That is usually less than 1% of the city's population that's driving over 60 to 65% of the local community violence. And so it doesn't require an incredible amount of resources to attack the challenge. What it does require is very focused, data-driven, targeted resources to actually impact the challenge and to approach it more as a public health challenge rather than just a criminal justice challenge. And so having kind of what we like to call the carrot and the stick approach, where law enforcement, as she laid out, brings the stick in terms of holding people accountable. We found that these initiatives are only successful if you also have community leadership that is deeply engaged with building relationships with people who are at the highest risk to commit an act of violence or be a victim of violence. The data has also gone on to share over 20 years of practice in this discipline that usually the perpetrators of community violence and or gun violence are also its victims. And so when we engage the challenge, if we don't look at the risk factors that are involved, actually facing an individual, will treat one part of someone's risk factor without treating the other part of it. So a part of what will be happening over the next several months in partnership with the police department is to really build more shared knowledge in the community in Salem about this issue. How do you raise language? How do you raise best practices? How do you begin to distill what resources are already within community, and how do you actually help organize them together so that the resources that are active aren't acting apart from one another, but are actually acting in more collaboration and harmony with each other. There's 3 public events that will be happening, 2 in July, 1 in August. That's being guided by what we've now founded, which is a community working group that's made up of public safety leaders, health leaders, faith leaders, formerly incarcerated leaders, education leaders that are all working together to shape what these public events and education experiences will look like. Our firm will produce an evaluation report by October 15th to the police department that will be available to the public that helps to identify, as we educate the community, what are we missing? And so I think there's practice, you can pay attention to certain symptoms, but sometimes, but what are we missing? And get a little bit more nuance that really has the city in a strong position to roll out an initiative coming into 2025 that will both hit everything that the data is showing us, but also be responsive to the kind of obstruction spots that the data does not show us. So I think that's what I would add. I'd really encourage folks, if you are interested in the data around it. It's a long report, but even if you go through the exec summary, which isn't too long, it helps to highlight the many kind of components of it. And for the period of the initiative that I was a part of in Oakland, we were able to reduce gun-related homicides by 50% over 5 years. And that was particularly because of the interagency collaboration that was happening on a regular basis and approaching it as both public health and a criminal justice issue at the same time, rather than choosing one or the other. So we're excited to collaborate and see some similar results in Salem.
And Jamal, there was a question in the chat that I answered, but I did mention technology as being one of our tools. And the question was, well, what technology is that? I won't give all of our secrets away, but I will mention that automated, we call them ALPRs, automated license plate readers, are a key technology. We already have them. We've had them, actually, I guess it's not really new technology. We've had them at intersections for quite a while. So it's not like facial recognition, nothing like that. It's grabbing license plates, and that we're able to identify cars leaving scenes and identify who's, who the car belongs to, and start that investigation that way. So that's one of our one of the ways that we're using technology.
One quick response I would say to the question from Caroline in the chat: the role that healthcare providers, leaders can play is a critical one. For the groups that I have sat on, having communication as a part of, let me say it a better way, have healthcare leaders that actually work in trauma spaces with folks that are impacted by gun violence or community violence, or work with families. Us being able to leverage those stories in service to the direct communication that we do with people that's involved in community violence has always been a critical factor. What I mean by that, one clear example, we had a trauma nurse that would come into some of the targeted communication experiences that will likely happen in U-All strategy in 2025, and have her talk about the experience of a gunshot victim or someone who's experienced trauma and the impact on that person, the impact on their family. We have found that most people that are engaging in community violence are doing so without clarity about what their lives will look like after experiencing the trauma of gun violence or community violence. And so having a healthcare professional be able to talk about what their lived experience will look like if they don't make different choices has always been a very catalytic role. The other thing is having healthcare leaders that can help us think about and understand, based upon how the healthcare system relates to victims of community violence, how can we co-create the ways that still protects patients' rights, to think about, well, when we're treating people, we call the police. Are there other ways that we can build into the system that community response teams are also called? What can we do within the system that is created that actually helps to involve the right kinds of community members into the healthcare system to help reduce potential violence, rather than only there being a relationship between the healthcare system and the criminal justice system? Usually that infrastructure needs to be built out. And if we have the right kinds of health leaders to be in some strategic calls, we can figure that out.
Great. Thanks so much, Ben. And I anticipate this will be an ongoing conversation with our clinical advisory panel as a lot of the planning work for the Community Violence Reduction Initiative is happening right now. And so all of your voices on the CAP will be incredibly important as that comes to fruition. So I want to thank our special guest, Ben McBride with the Empower Initiative and Deputy Chief Debbie Aguilar. Appreciate you two sharing this very important information, and we will definitely be in touch. So with that, I'm going to move us forward here and turn it over to Zaira for our quarterly quality incentive measure update.
Hi, good morning, everyone.
I'm sorry, Zaira. This is our extended meeting where we usually go an additional 30 minutes for the quarterly health IT update as well.
Mhm.
We're running a little bit behind, but I do want to carve out some time for the QIM update. We did have another THW presentation, especially how that connects to the HOP population, that we're going to postpone and bring that back for a follow-up discussion. So we'll go ahead and proceed into the QIM update and then switch gears over to health IT.
All right, awesome. And then Jamal, can you remind me how much time I have? I want to make sure I leave enough time for Mary Ann.
Yeah, certainly. I think if we can keep it to 5 to 10 minutes, we should be good.
Okay, awesome. And then I'm going to share some slides that I put together for you all. It should not be anything new. These are just based off of the QIM reports that we share with this group and the board. But I figured I'd put them in slides just to make them look prettier. So if you don't mind, Jamal, I'll be sharing my my screen. All right, I hope everybody can see these. Yeah, okay. So my name is Zaira Flores Marin. I use she, her pronouns, and I'm the CCO director for the Marion and Polk region. Today I'm going to be giving you all a Q2 update on performance based on all the different quality incentive measures that we work on throughout the year. Just as a reminder, August is when the OHA publishes final targets for 2024. So all of the data that I'm referencing here in the next few slides is going to be year-to-date data that we keep internally within PacificSource and that we use based on claims and based on some of the reporting that providers give us through their EHR systems. Additionally, in order for us to get 100% payout for this year, we do need to meet 12 out of the 15 quality incentive metrics to get a 100% payout. So since we don't have a lot of time, some of the metrics that I will be focusing on are the ones listed on the screen: the adolescent immunizations, the childhood IMSS, well child visits, the diabetes poor control, and the oral evaluation for adults with diabetes. These are the ones that we're focusing on quite heavily. They're the ones that our data is showing that we need to do some additional efforts around to make sure that we're hopefully meeting the targets that we need for the region. So for the adolescent immunizations, this is one that is used for combination 2. And here's some additional information on what it goes into the combination 2 vaccinations. So on this slide, you can see the first SNP is this year through the end of May. And then the second SNP, it shows where we are for performance in comparison to where we were last year at the same time. In 2022, we actually met this metric. We were very close as we were tracking the data. It was showing that we were a little bit under, but when we got the results from the OHA, we did indeed meet this metric in 2022. We're still awaiting final results for 2023. As you can see where we currently stand, we are above target. So this year we're at 32.1. Last year we were about at a rate of 29.9. So currently we are doing a lot better than we were last year. We are currently working with our Pop Health team, and we're initiating a pilot with 4 clinics that have a significant impact on this QIM. We will be piloting a gift card incentive program for adolescents who are coming back for their second dose of the HPV vaccine. Some of our provider partners have identified that this has been a barrier for a lot of teens once they've engaged with the clinic to get their first dose. Some of them have a difficult time coming back for the second one. And so we're piloting a incentive program to for them to get a gift card if they come back for their second dose, and then they'll also be entered into a quarterly raffle prize worth up to $150. And we're also opening it up for the raffle prize. We're opening it up for any teen that gets a HPV in an effort to try to impact population health. We're also tracking data really closely. So we have a few data reports that we're pulling to track the impact of the pilot. And the hope is that once we're through the pilot, we're able to analyze the impact that it has. And if it's something that shows fruition, then we as a health plan, we're wanting to maybe explore this in other regions and maybe also develop a more robust incentive plan. This is the first time Pacific Source has really looked closely at incentivizing members around vaccines. And so we're wanting to pilot this this year to see the impact it may have in getting teens to come back for their second dose. And based on that, we'll determine if it's something we want to explore and expand on next year. So the next one I'm going to talk about is childhood immunizations. So this includes children who turn 2 years of age during the measurement year. So it's kind of like we call it a moving target, since we have to track children's birth date of birth in order for us to also be able to figure out who's within the denominator and the numerator. In this section here, you'll see again, the top section is data through the end of May. And then the second snip shows where we are for performance in comparison to last year at the same time. This is one where, again, we're at 57.3, and last year we were at about 53.9. So we are doing slightly better than we were last year in this metric. So for well child visits, this one's about one well care visit during the measurement year by either a PCP or another practitioner. For this one, we are definitely keeping a very close eye on it. As you can see, again, the top is the data through the end of May, and then the bottom is in comparison to where we were last year. So currently we're at 20.6, the rate, and then last year we were a little bit over 23.6. We did not meet this measure in 2022. And so this is definitely one that we're putting a lot of focus on. We've been meeting with with all of the individual clinics. We are getting them gap lists, their need to treat numbers. We're working with them on doing we're kind of pulling together a little competition where the clinics who perform best, we are going to give them a prize. And then we're also working with our member support specialist team. We're pulling member lists, and we're looking at the members who fall within this age range, and then we're seeing if they've had a visit in the last 6 to 12 months. And for the ones that haven't, we're actively calling them to see if they need assistance getting in, if they need to find their provider. So our member support team is also doing direct outreach to our children within this denominator to make sure that we're able to get them in if they need assistance with any type of barriers that's keeping them from coming into their well child visit. The second measure is the HbA1c port control. So this is for the percentage of patients 18 to 75 years of age with diabetes who had a hemoglobin A1c over 9% during the measurement period. One of the things to note with this one is this is a provider-specific EHR reported measure. So we do get the data based on EHR and data, and then for some of the data we can't get through EHRs, we do chart audits as well. And so this is just kind of an estimate of where we're at. One of the things we're working on right now is I know Lavinia is on the call, so we've talked about potential project with Oregon Wellness Network to see if this, to see if we may be able to get folks referred to their recognized and accredited diabetes self-management and support services. We're also working with clinics to giving them gap lists, letting them know about the data, making sure that they're inputting the data incorrectly, so the measurement is correct.
Zaira, we've got about another minute or so.
Okay, wonderful. So this is the last slide I have, and then I'll send out the remainder as the slides, which breaks down the other measures. So this one's around the oral evaluations for adults with diabetes. And for this one, as you can see on the data, we're currently performing a lot better than we were last year. So we're at 10.4 rate versus 7.9 last year. For this one, we are lifting monthly diabetic dental days in collaboration with Capital Dental. And we're also sending letters to we sent letters to our members in March, and we're also going to be sending them. We've sent them in June, and we're also sending them in September to remind them about dental care. And then it's part of those letters also include a dental RX pad. And so we're continuing to do that and also collaborating with Capital Dental to try to continue to drive our numbers up. And then just as a reminder, these are the year-to-date lists that you all should be getting. We send these out to the Health Council for distribution to the different committees. So you can dive a little bit deeper into all of the different measures. We also send one that's a rolling 12. And then we also send out an ECQM report for the quims that are based on ECQM data. So I will send these out to Jamal so I can resend them out to the group. But here's more the data that we are sending to this group in order for them to kind of stay on top of where we're at with our performance.
Thanks, Zaira. And it's very important information. And I want to give our CAPA an opportunity to ask any questions or share any thoughts with Zaira. Dr. German?
Hey, Zaira. Yeah, hey, thank you for that information. I was curious in regards to the well child checks and in reference to immunizations as well. When you're discussing with provider groups or health system and clinics, have we discovered any changes as far as outreach in the schools and also providers doing exams and that, going to where the patients are at as a tool? It's something that I've done individually, but our clinic just doesn't have the bandwidth or the capacity. But some of that has been a strategy I think has been effective when we've done it for like our sports physicals and things like that. There's challenges with the immunizations and bringing those, but certainly those connections. I would just be interested in my question surrounds of, what have we learned that our partners are doing that have been effective strategies that perhaps like my own clinic could learn from?
Yeah, so thank you. That's a really good question. So definitely capacity has been one of the challenges our pediatric clinics have been faced with, especially when we start getting into those months where kids are coming in because they're really sick. And so so a lot of the times the well child slots get filled up with urgent care visits for kiddos that are experiencing some illnesses. So that's one of the biggest barriers that providers are experiencing. I just met with Chaos, and they were also saying that one of the challenges that they're starting to see is that parents aren't bringing in their kiddos because of challenges with like transportation, or they're having several much higher than normal no-show rates for their well child visits. And so they've been working within their clinic, they have community health workers that help their members come in and kind of help through some of the barriers. But they were just sharing with me that their healthcare workers are currently very strained right now. And so we're going to continue to have some more conversations to see what are some of the additional resources that we can provide. We do have a member support specialist teams that they help meet SDOH needs for our members. So we're going to be meeting with them to kind of talk about, what are some ways that maybe we can provide or upgrade some of our resources that we have available. And then in regards to the schools, I've not, at least this year, I've not heard of any providers going out directly to schools to provide any type of services. Again, I think that really goes back to capacity, and kind of their availability to do that. I know there are some clinics that have a very robust like outreach, so they use text messaging, phone calls. They'll engage with their members and try to get them in when they can come. They'll expand hours during the weekend and the afternoons. And so that's helped, but it's definitely one of those measures that there's just several things that are impacting and several barriers that go beyond just the clinical setting, that folks are having challenges with in bringing members back in.
Great, yeah. Just thinking of some of that, you know, something of the strategies, we do blocks of time for well child checks for our family docs, and we do it at certain segments, particularly summertime, because our urgent care visits are less, and prioritize that. And that's been one effective strategy that we've had, and just creating that opportunity in afternoon visits for families, parents getting off work and whatnot. Like I mentioned, we've done some stuff with the high school and the middle school as far as going out there and doing sports physicals. We haven't done that since COVID. Anyway, curious to learn more as that comes across your plate. Thank you.
Yeah, and this is definitely something that's an area of much interest to the board as well. When I gave them the presentation, this took up most of the time. And so I know, Jamal, you and I still have it on my to-do list to meet to talk about maybe pulling something together around strategy for this piece. This is definitely the one measure that it's kind of like all hands on board, because it's not looking like we're going to meet it if we continue the same way we are.
One last comment is that I do think the challenges we have is our ability and capacity to make phone calls. So if that's something that coordination of care could be collaborated on, we have a very robust network of people making a boatload of calls all the time. But if that's something that is in the space of this discussion for other resources, that I think would be wise.
Okay, wonderful. Thank you for that feedback. And I might reach out to you, Dr. German, as we continue these conversations.
I'd be happy to be part of that. Yeah.
And we do have our shared savings funds as well. So continue as members of this advisory panel to bring your ideas forward. We're more than happy to liaise with Pacific Source and Zyra to roll out innovative approaches to ensure that we're making as much progress on our incentive measures as possible. Okay, we are behind on time for our health IT update. So I'm going to shift gears and turn it over to Marianne Hannum with Pacific Source and Ryan Hart, who are with their health information technology team, to dig into some cool use cases for the collective system through point-click care, and ensuring that there are alerts for patients who are admitted, discharged, or transferred at the hospital. So I will stop rambling and turn it over to Marianne.
Hi, thanks, Jamal, and good morning, everyone. As Jamal said, I'm Marianne Hannum. I'm the Health IT Program Manager here at Pacific Source. Just a quick reminder, Pacific Source manages a CCO Health IT roadmap that's required as part of our CCO contract with OHA, and it really has the goal of raising awareness and adoption of health IT across the CCO region. For today's update, I've invited Ryan Hart to share a brief highlight of point-click care. As Jamal said, many of you might know PCC as Collective. If you're from the hospital systems, you probably know it as EDDI. Ryan is a care coordination HIE strategist within the Pacific Source Care Management team, as well as our internal Pacific Source subject matter expert on the PCC functionality. So I'm going to turn it over to him quickly for just, an update on what is this hospital event notification system, what does that mean, a few benefits, and why that matters. So Ryan, if you're ready.
Yeah, thank you. And one quick note too, just on my position, that my background is clinical. So I was doing acute inpatient social work at St. Charles and Bend before this. So I've learned a lot about the IT in the last 4.5 years, but I always like to start out to make sure that people aren't looking to me as the IT expert necessarily. So point click care, there's kind of like a couple of different ways it's been used. I'm going to try and be real brief because we don't have a lot of time, but essentially there's kind of the original usage it had, which is following up with people for discharge notifications from the hospital. So whether it's following up with with children with asthma, following up with people for the initiation engagement treatment metric, things like that, where you then do the increased care coordination, you identify people who are at greater risk, or we have the admit, discharge, transfer notifications at skilled nursing facilities, for example. So maybe you're a primary care practitioner, and you want to make sure that someone that's in your care that as soon as they leave the SNF, so you can check in with them, make sure they have everything they need and what they're doing. There's also a lot of other uses, and we're kind of coming up with new things all the time. And a good example of that, working with Kelly Borsbury at Northwest Human Services, is we put together a notification report for her for when a kind of a subset of her population, which is most of her homeless members that she can't get in touch with for whatever reason. So lack of address, not having a stable phone number, things like that, where she can actually get notified when they're in the hospital. And can pop over there and do case management, things like that. So there's both that kind of that follow up after discharge. You could also find some ways, if you needed to work a specific population and get in contact with them, that you could do that using kind of real time notifications. And there's a lot of other potential applications. I would think of health information exchanges as I think of it kind of as like a tugboat versus big steamer, like steam liner that's cargo ship. You have the big guys, carry all the weight, but they don't move that fast, and that's kind of the EMR, right? And they don't really respond that much to your attempts to kind of change them. The HIEs are really malleable and really adaptable, so it's less of a this is what we're doing with them, and more of where are the problems you have with your information, especially if you're getting that information too slow. Point click care, the delay in the information you're getting is about 30 to 90 seconds. So if you're having, say, a QIM issue and by the time you get that claims-based report, it's too late. Maybe there's a way to improve the speed there in in point click care. They've changed the name twice since I've been here, so you'll hear me going back and forth. Some of you might remember Pre-Manage as well. And then I think just the gaps in the system that you're talking about, that's where it really excels within the narrow range of the information it gets, which is kind of admit, discharge, transfer feeds from hospitals. All of the inpatient psych units in the state. Most of the SNFs in the state, the only inpatient psych unit that's not on board is the state hospital, and they're like right in the middle of coming on board, so they'll be there soon. Within that information, because it's so customizable, you can kind of mix and match it in whatever way you want. I think of it as just like this endless bucket of Legos. You can create anything that you want that you can imagine, as long as it falls within the the parameters of the information that's available. And then there's lots of other possible things. We've lifted up some ambitious things and not been able to get it done. We've also lifted up some ambitious things and been able to get them done. So there's a lot of new possibilities out there as well that we just haven't explored, and that's part of why I have my position. The only other person that I know of in the state of Oregon that's employed kind of to go out and actually do this development is Summer Sweet at Care Oregon. So she knows a lot as well. She's been here for a little bit longer than me too. So we work together pretty regularly. We created the IT metric and are working right now on updating it since we're a lot of dates. So things like that. That's my real fast version. And I would just say anyone here or anyone that if they need help with anything, or they have questions or they have ideas, my whole job is to do that development and that exploration for you, so that you can kind of go back to your work of actually helping people. So if anyone ever needs anything, I'll drop my email in the chat. Please consider it open door. And this position is really a position that was designed in service to you all. So I'm really kind of here to do the work for you. Happy to do that. I'm happy to chat with you, whatever you need. And I will stop there and hand it back to Mary Ann. If you have questions, I'm happy to field them in the chat, or you can ask them. I'm not sure how you want to do that, Jamal, so I'll do that to you actually. But thank you for having me, and thank you for all that you guys do.
Great, thanks, Ryan. And I did add both Ryan and my contact information into the chat window. So please do reach out if you have any questions. Just a quick call out about the Point Click Care platform sponsorship. So as part of the Pacific Source contract with PCC, we have the ability to sponsor the use of Point Click Care to providers who are contracted with Pacific Source to provide services to Medicaid members within the CCO region. What this does is it gives access to what Point Click Care calls its standard ambulatory program, which is a basic group of, I think there's about 7 cohorts around patient hospital encounter activity. I'm pretty sure that list includes the ED visits, ED discharges, inpatient admissions and discharge. And then I think there's a few, like 3 or more ED visits in 3 months, 5 or more in 12 months, and also a behavioral health ED encounters cohort, I believe. So there are a few caveats around the sponsorship that could bump that Medicaid provider into what Point Click Care considers more of an advanced user category. If that happens, there would be an additional cost incurred by the provider. They look at the size of the patient panel. If there's more than 25,000 patients in the panel, that might trigger that change. Or if there's any, heavy customization of reports and cohorts. But we have found that many of our Medicaid service providers actually fall within that standard category and would possibly be eligible for that sponsorship. So if there's any questions about that, please feel free to reach out to Ryan and I. Any questions about functionality, you're just curious to learn more, we'd love to talk with you. So Jamal, I'll hand it back to you. I don't know if you have some closing questions. You want to take any additional comments?
Certainly. Thanks, Marianne and Ryan. I'm so glad that we're able to offer this information because it's powerful, right? So as a contracted Pacific Source provider, which most of you are, you've got the ability to really get onto this platform sponsored by Pacific Source at very limited or no cost to your organization under that standard package. And what does that do? I mean, that empowers you to understand when your panel of patients are admitted, discharged, and transferred from the hospital. And then in terms of Ryan's work, Ryan is a powerhouse when it comes to building reports for our clinical partners and helping them better understand how to proactively connect patients with care and keep them on a path towards positive health outcomes. So really want to encourage folks who are using the platform already to consider connecting with Ryan and leveraging his analytical and report building capacity. And for those who are not on the platform, but you do have a patient panel, consider reaching out to Marianne and Ryan to get on board. One of the things that we do want to follow up on with this group is a brief survey highlighting some key use cases for not just Point Click Care and the collective platform, but all of the health IT tools under the Pacific Source Health IT roadmap to understand what are some of the priority uses for health information technology and health information exchange from our CAP membership. And from there, we're exploring the feasibility of opening up a sort of tailored learning collaborative that really addresses a key use case and allows us to share lessons learned and challenges and tips and tricks and success stories for how best to leverage these tools that are being sponsored in our community to drive outcomes for our members. So more to come on that. I want to pause for a moment as we've got a couple minutes left and just open it up for any questions or thoughts for Marianne, Ryan, or myself. Okay, and I see Lavinia had a question around access to a certain subset. Can we get additional access through Pacific Source? I think that's a great question, and I see that Ryan answered part of that question as well. But one aspect that I did want to touch on is if there is additional access beyond the standard-based package that Pacific Source sponsors that a provider entity or organization is interested in that really ties to an innovative use of the platform that folks think can really drive better health outcomes for your patient population. I think that's a great area for us to consider getting a cap shared savings request in the process and vetted through. So we've got an additional source of funding to go beyond just that standard based package as long as we can tie it to really advanced clinical interventions that are going to move the needle on quality in our communities.
Yeah, I'd say in just like a kind of a general sense, that we're always happy to explore stuff like that. And really what it comes down to is there already an established business relationship and specific like HIPAA guidelines for the information that we want to share? And sometimes that's the case, and we have information that other people don't, and we have all of the legal framework in place to do that, and it can be relatively simple and straightforward. Sometimes it's more complicated, and that's where, when it comes to me, since I'm really kind of a narrowly an expert just in this, if it requires kind of bigger legal things or bigger lifts, as you know, Lavinia, because I fell short of one for you, unfortunately, then it becomes a bigger question, and especially when the human systems get involved. But sometimes it also ends up being really easy. So we're always happy to have that discussion.
Great. Well, thank you again, Ryan and Mary Ann. So please be on the lookout for an upcoming survey. We'll really look to gather your insights and priorities for a health IT, health information exchange sort of learning collaborative. So more on that in a few days. Thank you all for holding on for our extended CAP meeting this month. We'll look forward to connect with you in July, where we will be engaging in our Forces of Change community health assessment input session, specifically for our CAP membership. So that'll also be an extended meeting. With that, thank you again, and we look forward to working with you moving forward. Take care, everybody.
Thank you. Bye-bye.
Bye, everyone.